Dr. Staci Beamer, who is going to tell us all about minimally invasive surgery for esophageal cancer. Staci joined us a few years ago. Dr. Beamer did her training at UNC, where she was a medical student, a surgery resident, and a cardiothoracic surgery resident, I believe. And then we were very, very fortunate to recruit her soon after her graduation from UNC, and she's been with us for several years now, and she is our go-to person for minimally invasive surgery and leads our robotics program. Dr. Beamer.
Thanks, Helen, for the introduction. Before I get started, I have no relevant disclosures or financial interests, but since I'm giving a surgery talk, I don't know how many people here are very surgeons and or super familiar with this type of stuff. So does anyone have any questions about this, some kind of burning question about esophageal surgery that I could address at the beginning before we get started instead of flipping it towards the end? All right, sounds good. So objectives, obviously review a little bit about staging and treatment pathways, review the various surgical options for esophageal cancer, including the role of minimally invasive surgery, and then discuss some of the common things we see on the surgical complication side in our outcomes. So you guys have been exposed to some of this stuff at the beginning, so I'm going to go through it pretty quick, but worldwide squamous cell, U.S. adenocarcinoma. So estimated over 17,000 cases for 2018 and almost that many deaths, unfortunately. Adenocarcinoma of the esophagus and proximal stomach are in the fastest rising malignancies over the last decade. And this is the typical U.S. patient, a little bit overweight, does some smoking, has some reflux, all the good things. So in terms of how these people get diagnosed, obviously barium swallow in some, and then followed by EGD for further clarification. And then staging, once they have a diagnosis, EUS, and Dr. Fukami went over that quite extensively, so I won't. A staging with imaging, contrast CT, abdomen, chest, abdomen, pelvis versus PET scan. Thoracic Surgery Society recommends PET scan. If that's not available, the NCCN still recommends that CT, chest, abdomen, pelvis is comparable. If the tumor is located above the carina from a surgical perspective, we'd like to perform bronchoscopy to rule out any kind of invasion. And if it's a locally advanced GE junction, diagnostic laparoscopy can be suitable for some of these patients. We don't routinely perform brain MRIs, only done if indicated. So benefits of EGD obviously gives us a lot of information and a roadmap about the tumor. So for surgical planning, this is quite essential. Allows visualization of the entire esophagus as well as stomach with retroflexion views, and then gets us tissue which we can do adequate testing on. This is just a diagram or a